So today I'm going to spend a little time talking about what I have focused on for the last several years that I have been here. As a fellow, I became interested in research, and we see ourselves as vascular surgeons as all about limb salvage. And I frequently felt as if I was not the limb salvage surgeon, but the limb taking surgeon. And so I really wanted to look at limb salvage and amputations in California. And there was a lot of literature that spurred my interest in this, and I'll go over some of that. I have no financial disclosures. And of course, these are some of the objectives for today. We're going to talk about the trends in preventable amputations. My work has mainly been focused in California. And then we're going to talk about hospital factors as well as patient factors that contribute to amputations. And then I'm going to introduce some of the qualitative work that I've been doing. And I must say that as a surgeon, doing qualitative work can be time-consuming, and it can be challenging because there are all these parts of qualitative work that we sometimes are not equipped to do. When you talk about amputations in America, about 2 million Americans live with an amputation, and about 54% of those are due to peripheral artery disease or to diabetes. And of patients who have an amputation, about 50% of those die within 5 years. And I think that's very relevant whenever you're on our service and you see how sick our patients are. And when you talk about patients with diabetes who undergo amputation, there is a very high rate of patients who undergo subsequent amputation. When we look at wounds on feet, which is what we tend to do, we break them down into two categories, those due to diabetes and those that are potentially due to arterial disease. And when you think about diabetic wounds, they're almost always on the weight-bearing surfaces. And they're frequently caused by neuropathy. Neuropathy is more than just numbness in the feet, and I talk to patients about that. Neuropathy is also loss of the innervation to the skin so that you don't get oil produced into the skin, and it's also loss of innervation of some of the muscles, and it's changing in the foot conformation so that patients end up getting wounds in these locations. Most of the time, if it's treated early, it can actually be treated with offloading. And very rarely do patients with purely diabetic wounds need revascularization. And the reason for that is that in some of these patients, when you look at their pattern of disease in patients who have diabetes and some of these with renal failure as well, what you see is that their arteries are not particularly diseased, especially in the aortoiliac segment and even in the femoral popliteal segments. But they will have lower vessel disease, small tibial vessels that go to pretty much nowhere in their foot. You can see on this last image right here, where this is the pedal arch, and you really have very few vessels going off into the toes. When we look at the national literature about trends in amputations for patients with diabetes, what we see is overall the trend is that there has been a decrease in the number of amputations. And when I show these trends, one of the things that's important to remember is the way that they came up with these trends. So the trends are determined per 100,000 of the general population. When you look at this top number here, this is all amputations, or this top line. And the greatest decrease has been in major amputations, which is seen right in here. But minor amputations have stayed about the same, if not increased just slightly. And this, again, is done in a way where they're looking at all patients with diabetes, and the denominator is the general population, which is frequently misleading because not all patients with diabetes are at risk for limb loss. When you talk about critical limb ischemia, it's a relatively urgent issue. We frequently see people who have had wounds for months. We have a patient right now in the service who had a wound for 6 months before he actually came to get treatment. But the treatment is essential in these patients for limb preservation, and revascularization is imperative. But these patients are also sick, and about 30% of them have a risk of amputation at 1 year, and about 30% of them will die at 1 year. And their pattern of disease angiographically is different. They tend to have disease where the arteries are atherosclerotic disease, which causes multiple areas of narrowing and even occlusion in certain cases. And for them, they may have patent tibial vessels, and they may actually have some very, very robust vessels in the feet. I think Dr. Pevic is more than willing to go to this vessel, even in somebody with renal failure, even though he's less enthusiastic about it over time. But these are very large vessels that you can bypass to. When we look at amputation trends for patients with PAD across the country, what we see again is this idea that they may be decreasing. And the orange bar here, this is broken up by region. The orange bar here is the Pacific area. But there are some of these areas where it appears that amputation rates may be increasing. And again, this data is done per 100,000 patients with peripheral artery disease in the region. The problem with a lot of this data is not everybody with peripheral artery disease is at risk for having limb loss. And that is what frustrates me frequently whenever I look at these studies, because I find that we are doing a lot of amputations. I find that we see patients further and further along in their treatment course, and sometimes we are not successful at limb salvage. And that's what started my curiosity with this when I was a fellow. The literature breaks things down into patients with diabetes and patients with peripheral artery disease, and the literature thinks of them separately. Even though when you read peripheral artery disease papers about amputations, they frequently have a diabetic group in there. And nowhere have they really looked at amputations per the number of patients with a wound. So these are the highest risk patients. They have a wound on their foot, and what is the risk of amputation in those patients? And that is where my research has come in. Instead of just looking at things as diabetes and peripheral artery disease, I was interested in breaking them down into 3 different patient categories and looking at rates in each of them. In addition, my goal was to look at the disease process and the amputation rates only in patients that are at risk for limb loss. So you're taking everybody who has a wound on their foot, you put them in one of these categories, and what is going on with these patients throughout California. And the reason I chose California is because there is this Office of Statewide Health Planning and Development database. It's a nice database to use. It's an inpatient database with emergency department information, and it also has some ambulatory surgery information in it. And a lot of our patients that have revascularization procedures are sometimes considered on an outpatient basis. It also captures data longitudinally. So you can follow a patient to multiple hospitalizations. You can follow a patient through multiple treatments. But the limitation is you really don't get a good sense of the clinical environment. And that's one of the things that I've struggled with this data with. But it also is able to look at where patients are treated relative to where they live. So it has a zip code of residence, so you can put patients in 2 categories based on where they live, and you can actually map a little bit of that. When I first started with this data, this was my very first year here, to get a good sense of kind of where we were and to look at this in the same playing field as what the other studies have done. I replicated some of those studies, and I looked at the 3 different groups, and I looked at amputation risk, again, per 1 million persons in California. And when I looked at this, again, I saw that there were trends of an overall decrease from 2005 to 2011. And in the diabetes group, the numbers had stayed relatively the same. But in the patients with peripheral artery disease and diabetes, and the patients with peripheral artery disease alone, we had seen a decrease. And again, these patients are all identified by ICD-9 code, and there's a very complex algorithm that Patrick Romano and I developed over the course of about 6 to 8 months, where we went through multiple reiterations to try and capture these patients and break them down and put them in specific categories so that they are mutually exclusive. But in the last couple of years of the data I had at this time, we saw a slight increase. And so the goal was really to investigate this a little bit more. My hypothesis was that amputation rates were actually not decreasing. And what I was seeing in my everyday practice of a number of amputations I was doing was actually more prominent throughout California. And I also was very interested in the disparities of care, or the disparities that led to amputations. A lot of times when they're using data, they're using things that are easily accessible in the data itself: race, gender, comorbidities. So we added to the data collection by developing specific indicators of access to care. The goal was to look at patient and hospital level factors. And the first thing I'm going to present to you is the patient level factors. When we started this data, we had about 78 million admissions throughout all of California. And again, we broke those down into unique patients, specifically identified by their disease process. And then we excluded patients who had a prior amputation. We wanted to look at these patients who had a de novo wound and look at them going forward. And we excluded patients who had had a prior revascularization. Shocking but true, in administrative data, there can sometimes be errors in the data. So there are about 155 patients who, for some reason, their coding of their death was before they had gotten their amputation. Clearly, that's an administrative error. So we took those out. We took out patients who were missing the sex data, or for some reason the patients had had some kind of a duplication. And it left us with about 169,000 patients that we could research. This is a breakdown, a very large table just to look at the differences between the groups. And the main focus here is that they are different in age. Patients with peripheral artery disease are the oldest patient population, and the mean age for them is about 78 years old. Versus the patients with diabetes are the youngest group. The mean age here is about 64. And the patients with overlapping disease of peripheral artery disease and diabetes, they're about 69. So when you I think of the age as one of the most important things. The comorbidities are also quite different amongst each of them. The racial composition for each group is very different. And all of these things needed to be accounted for in the model when we were going to look at amputations. The number of patients per year that were treated in the hospital remained relatively the same in each of the groups. But what we found is that when we looked at the number of amputations for these patients per 100 patients with a wound, what we found is there was a significant increase from about 10 to 27 in patients with peripheral artery disease and diabetes. This is the age group that's in the middle. For the oldest patients, there had been the least amount of increase in amputations. And then for patients with diabetes, the rate had increased somewhere between 5 and up to about 14%. So overall in this high-risk group, we had seen an increase in the number of patients that were undergoing amputation. And because the literature is filled with different reasons what they have, that people believe contribute to increased rates or the changes in rates, specifically racial differences and quality initiatives between hospitals, comorbidities, we put all of those into a model. And we broke that model down by things, race, age, and gender, things about the patient, comorbidities, such as end-stage renal disease. There is papers that have described an association between depression and psychiatric illnesses, and that those patients tended to have worse outcomes. And we looked at comorbidities, and then we added in some additional hospital factors and patient factors that we believed symbolized access to care, specifically patient prior ED visits and patient prior hospitalizations. We use this as a marker of access to care, but it is also a little bit about how much the patients can take care of themselves. If they have to keep coming back to the emergency room, if they have to keep being admitted, there are clearly some issues that they may have, or that they have trouble getting in to see physicians. And when we did all of that, we still, when we looked at amputation-free survival, we found that the youngest group, the patients with diabetes, had the best amputation-free survival, and that patients with peripheral artery disease and diabetes had the worst. And the patients with pure peripheral artery disease are right there in the middle, but the numbers aren't vastly different between the three groups. Because we have such high numbers, everything is significant. That's the hardest thing about looking this data, is everything has a significant p-value because we have such large numbers. But when we stepped back and we looked at what the different comorbidities really contributed, the idea in the literature that women do worse than men was actually not something we found. We found that overall, when you adjust for age and gender together, because they tend to interact, we didn't find that women did worse. And that's one of the things that the literature hadn't completely flushed out or even considered, the interaction between age and gender. Across the board, men had higher amputation or had worse amputation-free survival than women. In addition, we didn't find any racial differences. Again, because the numbers are so large, you have this p-value, but these numbers here are all fairly similar. And we believe that the reason we didn't see racial differences is because when we did this, we included things that really reflected access to care. And that is where we did see significant issues. We saw that patients that had multiple hospitalizations did worse than patients that did not, and that patients that had to come back to the emergency room, this is the emergency room, multiple emergency room visits, and this is multiple hospitalizations. And so clearly those patients tend to do worse if they have multiple hospitalizations, if they have multiple emergency room visits. And that makes sense. It's not rocket science what I've discovered here, but it is a way, what we found is to adjust for things you can potentially change to eliminate the variability in things that you see that you can't. Because I can't change the racial makeup of a patient. I can't turn them into something else. But I can potentially change how often a patient comes back into the emergency room, or even how often they need to be admitted. Maybe. I still think I can change a lot of things in the world. But the hard part with this data for me is that the outcome is amputation-free survival. And what drives all of these outcomes really is death. These are the death outcomes up here, and the amputation rates are much lower. And so that's the frustrating thing. When you're doing these analysis, you have to put death in as a competing risk, and that's something that we're just now presenting on, so I didn't include it in this particular data set. The other issue is variability throughout the country, or even variability within California. When you look at the number of amputations, these are divided by hospital referral region. Hospital referral region is something that the Dartmouth group came up with, and it is the way that patients typically are treated within certain areas, what hospitals they go to, focused around a very central hospital. And so by hospital referral region within California, there is this huge variability between places that have very high amputation rates, which I think in the Central Valley is something we would anticipate seeing, and then places that have very low amputation rates over in the coastal regions and places where we think that there may be larger or improved access to care. The issue with that is when you compare it with revascularizations, so these are the number of procedures that are done to, and this cohort is all patients with peripheral artery disease. When you compare it to revascularizations for patients with arterial disease, which we believe does decrease the risk of amputation, you can see here that these areas with very low number of revascularizations have very high number of amputations. That makes sense to me. But what about these areas here where you have very high number of revascularization procedures, but you also have very high number of amputations? And I really wanted to break this data down a little bit more and look at that. Because I do, and I think a lot of us being here at this institution think that there are hospital factors, or that we're constantly looking at hospitals and the quality of them, and certain hospitals are definitely better than others. So we looked at hospitals and we characterized each hospitals based on their experience with wounds, the number of patients they saw, the number of amputations they did, and sort of created this ratio of amputations per wound experience. And we also looked at revascularizations and what was their experience with revascularizations. We broke hospitals down into a category of the low number of wounds, low number of revascularizations. And then when we looked at the rate of amputations by these hospitals, we found that clearly patients that saw a lower number of procedures had a lower number of amputations, but the patients in the medium to high group were relatively similar. The main p-value difference here is between this low group and the other two. We also found that in patients who do a low number of revascularizations, they also had a low amputation rate. That's a little interesting, however. We think that that is typically an artifact that's seen because they transfer a lot of these patients out. And the patients that do the overall bulk of the work, the medium and the high volume places, the amputation rates are also very similar. When we looked at the model where we put all of the patient factors back in and we looked at the rate of amputation, and this goes back to the data I just showed was at the hospital level. This is now at the patient level. So if a patient presents to a low risk or a low amputation center versus a high amputation center. So we've gone from looking at just the number of amputations or how the hospitals do to saying if you as a person go to a low amputation or a low wound experience place, what is your risk? Or if you go to a low revascularization hospital, what is your risk of amputation, including all of your comorbidities? And in that case, we found that there is a higher rate of amputation if the patient initially presents to one of these low wound experience hospitals, and that if you do go to a higher, a place that does more revascularizations, you have a lower risk of amputation. These numbers were not statistically significant, however. And then when we looked at where you presented, so if you go to an outpatient facility versus being presented in, or if you go to the emergency room, and if you come to the hospital, what is your risk of amputation there? And we found that people that are treated completely in the outpatient setting, these are the people who have access potentially to surgeons who can do revascularization, wound care in the outpatient setting, those patients tended to do better. We also found in this particular group, when we went back and were using hospital, that again, these racial disparities came back up. And that, again, tends to confuse people. So you're not seeing it in one study, but you are seeing it in another. So what are you not accounting for in these studies that are making these differences be more apparent? And that's whenever we went to mapping. And so we mapped out the number of amputations per 100 wounds throughout California. We were able, and this is based on where patients live. So when you look at places in the outlying areas, you can see there are higher amputation rates over here. This is Sacramento by the star. This is the Central Valley, and these are all of these blue arrows are sort of large hospitals in these regions. But we found that around the Tahoe region, there's a little bit higher amputation rate. Down in some of the other areas, in the Central Valley, we saw a higher amputation rate. Even in some of the areas such as in around Placerville and Lodi, there tended to be higher amputation rates. And so that is something I'm going to come back to at the end of the talk, but the goal then, when we saw there are all these differences, and trying to drill down onto what makes each patient different. What is it about patients that we don't know in terms of why there are certain patients that undergo amputation and those that don't? And that's when we set out doing qualitative work. And the qualitative work was quite interesting. We assumed that from these interviews, we would find these perceived barriers to care, specifically geographic location or socioeconomic status, education, and these chronic disease states that would really be the main drivers of why some patients were more likely to undergo amputation than others. And so we did these 20 to 35 minute semi-structured interviews. We sit down, we talk to the patient. Again, the patients, all of these patients have a wound. They have a lower extremity wound, and they're broken up by why they have this wound, or we consider them by different class. And we ask them these open-ended questions. What are you doing to manage your wound right now? How comfortable are you with your current provider? It's almost like a little Press Ganey thing. You know, we talk a little bit about providers. And then we talked to them, we introduced this idea of technology and medical care. Would you see a doctor over the computer? Would you be interested in doing that? Or is that a little bit foreign to you? And remember, these are all older patients, so the mean age in this particular group is in their 60s. But the extremes of it went from about 43 up to 80. We had one woman who was 80. And after doing all of these qualitative interviews, we sat down and we just read through the transcripts and we coded the data. You code the data based on patterns of that you see in the responses, what the patients continuously come back to, or what you notice in terms of associations. And when we looked at all of this data and all of the coding, things that tended to stand out to us were these huge emotional associations. Every single patient overwhelmingly talked about fear. And they talked about fear in their everyday life. So this is a woman that I've treated for a very long time, and she said, what am I supposed to do? Just put a plastic bag around my foot so that I can walk around? Because her wound was constantly draining, and she didn't know how to manage that. Even though she had been coming into the clinic routinely, these were some of the things that she was still struggling with at home. So fear is a big thing in these patients' lives, but they're also way overwhelmed. They just don't know what to do. They just cry. This woman said, I just cry. I feel sorry for myself. There's a lot of stuff that I'm so used to doing or that I was able to do before, and now I can't do that. One of the interesting things, however, is that we noticed that almost all of these patients were also passive observers of their care. So this is a gentleman who came in and he said, they were asking me, how long have your toes been like that? And I remember what his toes looked like. There were 4 toes, or I think it's actually a couple of 2. The last 2 toes, they're all black. They're black, mummified. They're clearly going to have to come off. And he says, I didn't know what they were talking about. I had no idea. And while I was down in the emergency room, it was a Friday night or early Saturday morning, I actually had a good look at my foot, and then I saw what they were talking about. The last 2 toes on my right foot were totally black. This gentleman came in. He actually had a revascularization. Those toes had to come off, but he didn't lose his leg. But this idea was something that we saw through multiple different interviews with these various patients, is they had become these passive observers in their care. People were taking care of them. People were telling them what to do necessarily, but they were not driving any of their care. And when it came to asking them about telemedicine, how likely are you to, because a lot of people believe telemedicine is the future. I'm kind of one of them. I believe all patients are going to just sit in their house and I'm going to talk to them on the iPad and it's going to be great and they're not going to have to drive from Timbuktu to come and see me. The main thing that the patients talked about was trust. How do I know that the person on the other side is a physician? And how do I know what their comfort level is with taking care of these cases or treating me? And that was something that put it in perspective for us so that when we are designing a telemedicine program, we address some of these. So the current state of where I'm at is that I feel that amputation rates are increasing in these highest risk patients. Patients with wounds, whenever we see them, they are overwhelmingly scared, or they're scared and overwhelmed. And we have to learn to address some of these. As physicians, I don't think we talk about these things with the patients very well. And they may not have adequate resources in their area, and that can lead to a risk of amputation. And not all patients are the most engaged in their care. And that's the word that I'm going to use as I sum up over the next few slides. Because I believe telemedicine is going to be a fix, but I also believe that learning about patient engagement is going to be important. Patient engagement is the idea that patients take some role in their care. And each patient can be a little bit different, but there are ways to manage or to measure patient engagement. And that is the next study that I am actually conducting right now or about to start. And that is where we've taken this patient engagement measure. It's a 13-question survey to assess where patients fall on this spectrum of engagement. And again, whenever we talk about this, this survey can then be coded and broken down into 4 different levels. Level 1 are these patients that are disengaged and they're very overwhelmed. They're very passive, they lack confidence, their knowledge is low, they have goal orientation is weak, their adherence is poor. My doctor is in charge of my health. Level 2 patients, they're becoming aware, but they still struggle. They have some knowledge, but they have these huge gaps. And they believe healthcare is largely out of their control. I could be doing more, is their perspective. Level 3 patients are those that are taking action. They have key facts. They're building self-management skills. They strive for these best practice behaviors, and they are goal-oriented. And then level 4 are those that are maintaining behaviors and pushing further. These patients have adopted new behaviors. They still struggle at times of stress, but they are maintaining a healthy lifestyle as a key focus. And so the goal of the new study is to actually, in the vascular clinic, to submit these patient activation measures to all patients, to get a baseline of where certain patient groups are. Are most of the patients that have critical limb ischemia who are a little bit older, who have these wounds in this level 1 and level 2 category? I'm clearly not necessarily going to be able to change them drastically, but maybe I can shift where they are in that category a little bit more. Or maybe I can design tools for these patients to help them, knowing that their resources are low and their understanding is low and they feel overwhelmed, so that we can prevent readmissions, so that we can prevent limb loss. We also want to get a feel for age variations. Patients that are seen in the hospital or come in through the emergency room versus those that are seen in the outpatient setting, and really understand this a little bit more. In addition, right now, one of the things that we're doing to research telemedicine is we're doing a new round of qualitative interviews. So this particular study is looking at about 25, or it's still doing 25 to 30-minute interviews. And now we're looking at how patients share information. So when you take a 80-year-old woman and you ask her to send you a picture on her iPhone, you know, some women aren't real, or some patients at 80-year-old are not that savvy. Some people, even at 60, can't get their phone to work and actually do something that you need to do. So we're trying to do a more structured, qualitative type question about how they share images. We're talking to them about that. Then we look at their comfort through sharing through mobile platforms. And we're also looking at their reaction to these telemedicine examples. They're given a picture of a patient with a foot wound and said, would you feel comfortable sharing this wound with your doctor? How would you particularly do that? And then they're shown a video-based interaction between a patient and a physician through a telemedicine channel, and we get their responses to that. And even in the older patients, what we have seen so far is they're highly responsive once they see what the example of telemedicine is. Now, I showed this map a little earlier, and when we're looking at how to implement our telemedicine program throughout California, we overlaid the current telemedicine program, which is the blue dots, with the map of where some of these high intensity amputation risks are. And we're really trying to focus our efforts to build a telemedicine program around some of these bigger blue dots in this region. So the programs that I have focused on thus far are Barton Memorial Hospital. Even though they do a low number of outpatient visits, this has been increasing, and they have a wonderful structure for doing telemedicine here. Marshall Hospital has an exceptional wound care facility that does hyperbarics as well as really some advanced wound care, and they're an area where we'd like to work with. Lodi is down in this region. Again, smaller number of patients doing doing telemedicine. Up in the Yuba City and Feather Falls area are other places that we would like to focus and try to build this telemedicine program. And the whole goal of this program and the grant that I just submitted is to teach some of these clinics how to pick up on arterial insufficiency early, teaching them a very quick ABI measurement that they can do within the clinic, teaching them a classification methods for patients with lower extremity wounds. The Society for Vascular Surgery has this Wi-Fi, Wi-Fi, you can either way call it one of those, but it breaks these patients down and it puts them in a category that tells the provider very quickly, this person is somebody who needs revascularization, and this is somebody who may not need a revascularization. And it helps these providers in outlying areas decide where to send patients and when to send them. And then our goal is to provide early telemedicine consultation for these patients in their near where they live so that they don't have to travel down here. So like any research, I find that frequently it's slapping me in the face and it's overwhelming how to take it all in and make changes. So I don't know that I have great conclusions, but I know that I just keep going and keep running. So I thank you for your time, and I'm happy to answer any questions.
Misty, that was great, and I found myself really thinking about what are the diseases of affluence, if you will, in terms of coronary artery disease and peripheral vascular disease versus what are diseases of disparities, and how you really drilled down on trying to answer those questions rather than just big lumps of people. Really great work. I think we have time for questions.
Misty, I enjoyed that. Foot care and podiatric care, obviously very important. There's quite a diversity of coverage in this state. It seems like the podiatrist's office might be a great networking focus for your telemedicine project. Do you have any maps of podiatry coverage in the state, and how does that compare to what you've shown us on the vascular surgery side?
Yeah, I don't actually have a map of podiatric services, but I have spoken with and worked with some podiatrists in certain areas. There's a wonderful woman up in the Tahoe region named Dr. Ferrara, and she has the ability to do some of this ABI type work in her clinic. So she can, when she sees patients, she has a machine where they do the ABI. It's actually sent to a remote physician who reads it and sends the information back to her. And being able to put some of those services into smaller clinics, or not really smaller clinics, but clinics that do a large volume of primary care is something that I think is an area that I'd like to explore. Because it is true, podiatrists are essential, I believe, in taking care of some of these patients. But there are also problems that we have seen. Not all podiatrists can pick up on arterial disease, and that's really important. So there's not a good way to look at where all the podiatrists are right now in the country, or sorry, in the state, but it is something that we can take a look at. So.
I commend you and your researchers because I think this is such a fascinating and very important area of research. This morning I heard a segment about Indian health services, and I think that it was enlightening in a few respects, and I'd like to hear your comments too. Basically, that's a little microcosm, but what really stood out to me was the disparity that they have in terms of access and follow-up. And it was an Indian health service nurse, and she essentially said life or limb is what will get them care, but it's the follow-up care that is often the difficulty. And she said if you don't have your care by June, there won't be enough money for the rest of the year.
Yeah.
And so I'd be interested to hear where that racial group fits into your research and how we can help that particular population, and where the payer mix or lack of payer mix falls into what you've been finding.
So we did look at payer, and I didn't spend a lot of time on that here because it was something that I found very fuzzy, and I think that when I look at the payer mix, I'm seeing a reflection of kind of the complexity or maybe the affluence of certain patients. What I found is that if you're a Kaiser patient, you have the lowest amputation risk. Well, isn't that just maybe the patients that are seen or taken care of at Kaiser? Is that really a reflection of Kaiser doing a better job maybe? Or maybe it is. Maybe it is all these structures that they have in place and they're multi-specialists and how their system moves seamlessly. So I've had even though I controlled for multiple factors, when I tried to look at payer mix, it didn't always come out cleanly. The Indian patient population is a very unique group. And so there are telemedicine clinics that we have set up at some of these facilities, and that's one of the things that we really wanted to include. We haven't yet made it a priority to reach out to some of those, but down in the Central Valley area, there is a particular group that uses some of the telemedicine. The problem with the telemedicine, however, is some of these patients don't have internet. So they have no internet resources where they are, and they can't set up the connection. And I didn't consider that or even think about that whenever I was considering those. And so that's one of the biggest problems that we have.
I wonder if on your map where you have the highest levels of amputations, if that would potentially coincide with some of these reservations.
Potentially. So. Yes, Dr. Greenholm.
So I noticed in your data, did you control for smoking or non-smoking?
We did.
Okay.
But it's, again, this is a big data set. Tobacco isn't always considered or coded very well. And we've seen that in multiple different administrative databases.
The other hypothesis that you could say about the higher amputation rate in the smaller communities is that, the general surgeon can do an amputation, but can't do a revascularization. So I cut a leg off, but I can't do a bypass. So is that
Potentially. And so one of the things that we want to do, and I'm going to apply to get new data because it's now 2017 going into 18, and I'd like to see a few more years of this data. But when we get the new data, one of the things we want to look at is if a patient is seen initially maybe at a smaller hospital and then goes to a larger hospital for treatment or a larger area, do those patients have lower amputation rates than patients that are only treated in their small community areas? What I'd love to actually do is get access to all-payer data, but that is incredibly expensive. So to get an all-payer data set, because I also believe when we've seen here that patients that have all of their care in the outpatient setting, how do those patients actually compare with their amputation risk to patients that have to come in and have to have or that are come into the hospital multiple times? So I think that that too would reflect sort of a higher level of engagement potentially, or access to getting care sooner. But I think that we would see a huge difference between patients who get all of their care in the outpatient setting, including their revascularization with a lower amputation risk, versus those patients who need to be admitted or different things like that.
It's sort of similar to Dr. Greenhalgh. So do you also control for whether that small hospital does endovascular procedure or open? I recently visited Kaya,
Mm-hmm.
and they service a 10 to 30,000 surgeon population. They have 2 general surgeons and 1 vascular surgeon, and the vascular surgeon does not use endovascular.
Correct. So one of the things when we looked at the hospital level factors is we also broke down how many procedures they did, and we classified each hospital as a primary open, primary endo, or a mixture hospital, places that could do both. And so we did control for that in the hospital level factor data that we did. So, yes, Dr. Cook.
This is great work, a wonderful example of mixed methods and a novel use of telemedicine, which is, I think, is really awesome. A couple questions. One is, and you probably didn't talk about this for interest of time, but in regards to amputations, it seems like binary, either amputation yes or amputation no. Is there a good amputation, meaning like if you just get a toe amp during the course of your treatment, and if you're in a less resource setting, that toe amp could lead to a BKA. So is it fair just to say amputation binary yes and no? And then the second question is sort of going along with Dr. Pham's question. The heat map between amputations and revascularizations didn't exactly line up.
Mm-hmm.
There are some areas where you question, is there an appropriateness of revascularization? Is endo better than open, or in some places open better than endo? And how does that affect into the calculus?
So on the first question, I will say, and I definitely failed to mention this, all of the amputations I'm talking about here are major amputations. My new project is looking at minor amputations, and that's something that I'm putting together actually for Jonathan to present hopefully in the upcoming vascular annual meeting, where we're looking at patients who had a minor amputation and what is their risk of major amputation afterwards. So that is some data that I work with the statistician at the Center for Healthcare Policy and Research, which you asked about, that she's working with me to come up with some of that information. In terms of revascularization, there is a propensity score project that I'm actually submitting for QCOR, the American Heart Association QCOR, where we're looking at endo versus open. The current randomized control trial that we participate in here at UC Davis is called the BEST trial, and that's the question that it has. Which is better, endo first or open first? When I looked at this data and I did propensity scores of all of the patients and then looked at endo versus open, I really found that there was no difference between those two in terms of the long-term risk of amputation. And I believe that that's what this study is going to show too, because this is a pragmatic trial that we're doing. You get told, they're endo or they're open, and then the surgeon kind of gets to choose some of the things. They have to have certain criteria. So there are some very important inclusion and exclusion criteria, but it's a little more pragmatic in how you get to treat whenever you do that. And so I think that what the BEST trial is ultimately going to show is that there isn't a huge difference between endo first or open first, and that each of them, Dr. Hediati, who did some research work with the OSHPA data, she found that when you did open versus endo for patients with claudication, both of them had very high reintervention rates. Even the open patients had high reintervention rates to go back and treat those areas. And I think that's what we're going to see, is both of them do fine, and both of them still have high reintervention rates. So. Yes, Dr. Pevic?
Something's going to change.
Sorry.
I think your emphasis on the qualitative aspects are going to be what's going to be the most important for this. So wounds on the extremity are different than most of the other things that we treat. So the patients don't get those wounds if they take care of themselves. This is frequently a preventable problem. Our patients don't have insight, and it's different than carotid disease, aortic disease, cholecystitis, cancer. The patients don't really have so much skin in the game if you go up with these ulcers. And unless we can engage our patients and get past the denial, it doesn't care no matter how great your system is, they're not going to do it. And we don't, that's a harder thing to study, and I applaud you, so it's more of a comment, applaud you for working at the qualitative aspect, particularly that scale of engagement. Because that's, if you make a difference, you can do all the great work for the patient, but they're not going to do their part. Those wounds are not going to do. And we see that and know that, but it's much harder to study, and look forward to you trying to figure out a way to get a handle on that, to figure out how to quantify that, and then how to change it.
Katherine Kim is a nurse who's at the Betty Irene School of Nursing. She's a phenomenal researcher in terms of looking at patient activation and use of technology. And Dr. Kim is the person who introduced me to this patient activation measure. And for me, I really didn't know much about it. And I think it is going to allow us to categorize patients so that we can focus a little bit more. It's very novel in vascular. Nobody has studied where the patient activation level is for these different diseases and how it varies. So I am interested in really just seeing, first off, what it looks like, and then seeing what we can do to implement it. One of my things that I'm in the telemedicine world is, can I overcome the lack of patient engagement by telemedicine? So perhaps patients don't want to come down and see me. They live in these remote areas. There's a reason they live there. There's a reason they don't come down to get care. Can I overcome their disengagement perhaps by by cramming telemedicine right into their house and getting them taken care of? Can I potentially do that? We'll see. So.
Anyone can, you can.
Thank you very much. Thank you for your time. I appreciate it.